Hello, everyone. Welcome back to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm joined by my co-host, Dr. Johanna Richey. How are you, Jo?
Oh, I'm good, Jeff. We're getting ready for the PodSurge 3 course, lining up all my little ducks in a row, and life is good. Can't complain. How about you?
Oh, I'm doing well. I know the students are excited for the advanced surgery course, so that's fabulous. And I'm in Columbus, Ohio. A little bit of rain. Not used to
Very
that.
close to our guest. Fantastic.
Yes.
Well, I guess more close than you would be otherwise.
Did you know APMA provides help with public health initiatives, such as fall prevention, opioid abuse prevention, and addressing health disparities?
Did you know the APMA provides over $400,000 in scholarships annually to students pursuing podiatric medicine, helping the next generation of foot and ankle specialists?
If you're serious about this profession, if you want to grow, to lead, to make a lasting impact, join APMA today.
We have a fabulous guest today. I'd like to introduce Dr. Andrew Mastay to Dean's Chat. Dr. Mastay, welcome.
Thanks for having me. It's a pleasure to be invited.
We're so glad you could make the time. Dr. Mastay, we're fairly informal on Dean's Chat. If it's all right with you, let's go first names, Andy, Joe, and Jeff.
That sounds perfect. That works for me.
Well, we're really excited, Andy. We really appreciate you taking the time to come chat with our audience about your experiences. And we'll start with kind of the formal introduction as we usually do, and then we'll kind of dive through different parts of your career as we go through the discussion today. But Dr. Mastay is currently practicing as a senior staff physician at Henry Ford Medical Group in Detroit, Michigan. He graduated from the University of Detroit Mercy with a Bachelor's of Science in Biochemistry and continued on to Oakland University, completing graduate coursework in chemistry prior to earning his Doctorate of Podiatric Medicine and Surgery degree from Des Moines University. Went on to complete your 3-year surgical residency training program with Henry Ford Macomb Hospital in Clinton Township, Michigan. And you are board certified in both forefoot and rearfoot reconstructive surgery through the American Board of Foot and Ankle Surgeons, as well as a diplomat of the American Board of Wound Management. Currently, you're also the president of the Michigan Podiatric Medical Association, and we're going to dive into that a little bit later. But what I would love to do is let's start way back at the beginning, Andy. How did you find out about podiatry?
So I actually have to credit one of my best friends, Brian Roy, who's a periodontist down in Toledo. We did undergrad together. I was a fairly shy guy, and in chem class one day we had to do a group, and he basically walked up to me and was like, "You're in our group." And that's how I got to know him. And we've become lifelong friends ever since. And so we were finishing up school. He was going to dental school. He already knew what he was doing. And for me, I really didn't know. I had taken the MCAT, but I wasn't like dead set. My heart wasn't set on going to med school. And I decided I wanted to do a PhD. I got really kind of into research the last couple of years of undergrad. And I was like dead set on neuroscience, going to go to neuroscience, wanted to do a PhD. Ended up, I got accepted to a program. And then this was 2009 crash, financial crash hit 2008, 2009. And about 2 weeks before we were supposed to start, they were like, "Hey, our funding got cut and we got to let someone go, and it's you." And so I was kind of left with my hands up in the air. As what do you do? I had this whole plan set up. And so I ended up calling one of the local colleges, Oakland University, right up the road. And I was like, "Hey," I explained what happened. They were wonderful. I basically gave them my GRE scores and stuff. They were like, "Don't even apply. Here's a number. Go ahead and register for classes." So I got in, and I kind of did just a year of master's coursework in chemistry just to do something. And I was like really lost on what to do. And Brian actually was like, "You need to go do podiatry." And I was like, "I am not going to cut toenails. That is not what I'm doing." And he was like, no. And he actually is the one who like went into like explaining everything, got me to go shadow someone, and then took off from there. So.
What do you know about podiatry? You said he was a periodontist?
Yeah, so he was going back and forth between podiatry school and dental school, and he wasn't sure. I think truly he wanted dental school, but he was still kind of going back and forth a little bit. And so when I was kind of left, he was like, "You need to go do this." And he's the one that pushed me. So,
Jeff, your thoughts?
Well, that's fabulous, and you know what? It's not uncommon. It's a circuitous route into our profession, Joe. I mean, we see that every day when we're interviewing students, and I've seen it for the last 15 years interviewing students. Very few students, unless their mom or dad's a podiatrist, you don't see people in middle school saying, "Hey, when I grow up, I'm going to be a podiatrist." So I think it's incumbent upon us, our generation, to get the word out there to the American populace about what podiatry is.
Yeah, for sure.
And I love your take too, Andy, because it's a similar, if people know anything or have some kind of experience with podiatry, it's like, oh, I think I took my grandma to an appointment. And so the perspectives too of what we actually do on a day-to-day basis are fairly diverse. And it's very few people, I think, that have a toenail practice. Like, that's just not what podiatry is anymore. So I'd love to kind of transition to that, because your surgical practice is also somewhat unique in that most podiatrists kind of fall under subdivision of ortho, and you have a lot of expertise in this arena that's continuing to expand for podiatry, which is orthoplastics. Can you talk a little bit about what your experiences are, what you enjoy the most about the work that you do, and some of your multidisciplinary work that you do?
Yeah, for sure. So, I mean, I think a lot of this stems from when I first got out. I joined a private practice. I was in a private practice for about 6 years. And, they kind of tossed me in and were like, "Hey, you got to go kind of build your own practice." I think one thing, number one, I guess, coming out is you have to, I feel like, especially nowadays after COVID and everything, is personal relationships do so much. And so Kevin Kreitman was one of the guys I worked with. And he is forever my mentor. I'm forever indebted to him. And he used to tell me, "Go park your butt in the doctor's lounge." So that's what I did. I would go park my butt in the doctor's lounge. And I really built my first practice out of a hospital in the adjacent wound care center. What's funny is when I was going into residency, I was like, "I hate wound care. I want nothing to do with it. I don't want to do any of it." I was all, "We're going to do trauma. We're going to do elective. I want none of this." And when I got out, it was kind of like, how do you start? Where do you go? You just can't. Cold calling someone walking into an office, to me, is just not my style. I don't do well with that. So between the wound care center and the hospital, I found that I was able to kind of build some of these relationships. I'd walk around real slow behind all the docs in the doc lounge, and you can see the last name at the top of the computer screen. And I'd find a patient that I had that they also had, and I'd be like, "Hey, we have a mutual patient." And I just try and start that relationship. And so that's how I kind of got into more of the hospital work from the get-go. And then what I actually found was that I was much more satisfied taking a patient who even ended up with some level of partial foot amp, and they saved their leg or you helped them, than I got from fixing someone's bunion. I didn't find the same level of satisfaction. And I know some people love the other. It's just, for me, that's what clicked. And I also liked, kind of being in the hospital setting. One thing I didn't realize coming out is kind of how lonely it can be as a practitioner. Sometimes I feel like we're in these offices, we have our front staff, we have our receptionists, we have our MAs, but I guess more so in a private practice than maybe in a system setting, you're their boss. You can't always be their friend. And so when you're the only provider in your practice, sometimes, your MAs and your staff, they're all getting together, they're going out, they're hanging out on the weekends, they build these relationships. And while you can joke with them, you can have a great relationship, you always got to keep some level of separation if you're at some level, managing them. And I think I didn't realize how almost lonely it was sometimes sitting there in an office, just doing my charts, seeing patients. And I found that in the hospital setting, you have other providers all around you, and you start to build the relationships, and you see them on a day-to-day basis. And I liked that atmosphere, and I liked starting to collaborate, and I liked the text messages and the phone calls and discussing difficult cases. And what do you think about that? What would you do here? And then almost, I guess it's a little it's personal satisfaction when they start to actually reach out to you, and you start to find like, hey, they actually look at me like a real, like an equal here. I'm not just, because how many times do we hear, oh, you have 3 letters after your name, you're not the same. I mean, I heard it coming out. And so it's nice when they start to take you that way. And I feel like being in that hospital setting, I got that. And that's how that hospital work kind of took me there. So I guess that's a real roundabout way for how I ended up doing what I like. And then when I came to Henry Ford, I kind of, we walked in, and our downtown hospital is 700 something beds. I forget the number. And there was not an inpatient podiatrist. We had inpatient podiatrists at all these other hospitals, and there was nobody downtown. And who was managing it? It was kind of they come in and it was like a hot potato. You had acute care surgery, you had plastic surgery, you had vascular surgery, you had all these people, and nobody really wanted to manage it. You had some wound care nurses that were walking around and doing what they could, and there was nothing really there. And so about 6 months in, one of the people I work with, Dr. Brad, who was one of your guests not too long ago, she introduced me to the chief of plastic surgery there, and her and I started having conversations about how we could integrate me in. And so I kind of started, even though being hired under the Department of Orthopedics, as kind of a de facto practitioner for plastic surgery. And from there, it just kind of blew up to what it was. You'd start with, oh, we have 1 foot here. Can you come look at this? And I would start rounding with them on a daily basis. And then it became 2 feet. And now our list is somewhere between 20 and 25 on a steady basis. And we're getting, 4 to 5 consults a day. And everything we do is we're a surgical consultation service. So we don't do any of our routine care there. We just they call us for surgery. And so that's kind of how that built out. So it's been a process, it's about 3.5 years now in the making that we've been working our way up, but it's just the same process all over again. And again, I really feel like it comes a lot down to just personal relationships. And I guess that's the one thing that I stress. I don't know.
I love that, because I fully agree. There's so much to be said for showing up and doing the good work and letting your work speak for itself. And that's how Tim Yoho had said that the path to acceptance is excellence. And so I appreciate so much that you highlight this idea that how we treat each other really matters. And that doesn't mean you show up and you have expectations of what you deserve to be doing. You show up, you're a member of the team, you do your best work, and you start getting credibility, and that builds. And then you start getting a lot more collegial respect. And that changes culture. And it doesn't happen immediately. It does take time. But that is, in my mind, that's how we have big impact, certainly regionally and locally in our hospitals, but even nationwide. And I love that you highlighted that. Jeff, what are your thoughts?
I think it's interesting, Andy, almost by default, like you said, everything was scattered throughout the hospital and different people were taking responsibility, but almost by default with the patient with diabetes, podiatrist sometimes becomes the captain of the ship because someone's managing their meds, somebody's making sure the blood flow is appropriate, the infectious disease docs are involved, endocrinologists. But at the end of the day, that foot health ends up in your department. And I just think that, to your point, Joe, for collegiality and becoming part of that multidisciplinary team, I can't think of a better way for podiatrists to make a difference.
No, and I also think that it's kind of we can do a lot of stuff, but it's one thing that really sets us apart. Like I've heard so many people talk about how, we're everything foot. We're everything from the nails and the dermatology to the complex reconstructions, to the wounds, to the blood. Like, we do everything. We don't just focus on one system. We're a region of the body. We're not system based, which I think is very different from the way a lot of other specialties kind of focus. They focus on one. Yeah, sure, orthopedic has some regional differences, but they're still focused basically on the bones and osseous structures and the musculoskeletal system. we are all systems, but one region. And, I think the more we promote that and show people and teach them, it's one thing that really kind of sets us apart.
Absolutely. And Andy, what's it like practicing in Detroit? I mean, it was a central hub of our profession for decades. Did you get that feel? I mean, when you were coming up through the ranks, I mean, we're going to talk more later about the Michigan Podiatric Medical Association, but Detroit's had a very big influence on our profession.
It has, and I was born and raised here, so it's been Detroit love forever. Like I was, the first hospital I worked at is actually the hospital I was born in. So it was like it was kind of I knew coming up like this was going to be it, and then learning how much Michigan and Detroit in itself has influenced our profession. It was more just like now it's like I have to continue that on, and we have to continue pushing forward. And I love the city. I love downtown. And I really like the patient population that we treat down there. And like I said, it's not like I'm not going out here trying to be a martyr. It's just I get a lot more satisfaction from a lot of these patients that like when you'll sit there and spend time with them and they'll look at you and I've had one person who looked at me and they're just like, you actually talk to me like a person, not like a patient. Yeah. And just being able to go through it. Because let's face it, when you have someone with a chronic wound and we're managing this or, following an amputation, you build a relationship with these people. This is a little different than some of, your elective stuff. Like you're seeing these people sometimes every week for 3 months, 4 months, sometimes over a year. They end up getting another wound. They come back. Like you get to know their families. They get to know yours. You get to know what vacations they're going on, what foods they like. You have inside jokes with them. And it's one thing I really that part, that relationship I like. And I think that, Detroit has a ton of it. Now, I will say the one thing I wish we didn't have to do as much that we do is we do a ton of amputations. Way more than I'd ever like. And it's not that we're not able to save. It's just when stuff comes in, it's just so far gone. It's like, what do you do? But we're stopping them from getting a BKA. So, I mean, I'll take that as a win. One thing that I like to always point out is since we kind of came in and we've established something is, I believe it was, I have a resident doing the official numbers for me still, but we're real close to a 40% decrease in BKAs over a handful of period within the system. And, we even have like our vascular fellows who notice it. I have one general surgery resident who's going into vascular surgery and they want to go to a place with a multidisciplinary. And they said, because of what we've started here, they really enjoy the teamwork. Because when I first started, we didn't have podiatry residents downtown. So I would scrub with the general surgery residents, whether they're on plastics or vascular. And those were the residents I had. And even the vascular fellows and the plastics fellows at times, I would have them scrub with me. And so now we have the residents and they're in there, but we still have that relationship with a lot of them. And I really like it. So
there's a lot of truth, Andy, to the old saying that you have to play the hand you're dealt, right? I mean, when they come through the ER and you're in a pure limb salvage mode, functional restoration isn't the top priority, of course. Yeah. But I think that's always interesting. But I always recall, I think he was an orthopedic surgeon, Jesse Thompson, said sometimes the best vascular procedure you could perform is a below the knee amputation. And I'm not advocating for that, but sometimes that's true, especially with the advances in prosthetics and things. But you can only deal with what you see when you first see him that initial visit.
Yeah. And I mean, even I just had a guy the other day who he came in, he had a Charcot recon, and it looks like he had another event and he ended up with a wound and it got infected. And we basically we took bunch of pus out of the foot and out of the ankle. And I looked at him and he just said, I'm done with this thing. And he goes, it's time. I want to move on. And it's like, I sat down, we had a 20-minute conversation with him, but he's ready. And, my big thing that I've always preached to the residents or to whoever is always functional limb salvage. Like we have to look at quality of life and we have to look at what's the best functionally for each patient. We can give them a bunch of options, but we also have to be realistic with them. And I think that's one thing that, I think we do a good job of as a profession. I think that I think we do a good job all the way around. And I think that it's something we need to just keep pushing personally. So
that's a huge difference, 40% decrease in amputations. That's I mean, that's phenomenal. Congratulations.
And I think to your point too, Andy, this idea that as we become specialists of the holistic part of the foot and ankle and how it functions, this idea of a functional amputation, what is salvageable? What can we do to improve this patient's quality of life, to prevent them from re-ulcerating and being right back here? Versus when do you start having the conversation of, look, this may not work. And what do you want to do? How do you want to progress as the patient who will be living with this? And you're right, sometimes giving patients the space to go through that process. And it's fair to offer reconstruction with the expectation, like, it may not work. And you need to start mentally being ready that if we can save it, fabulous. But if we can't, you need to understand that possibly the next step is something much bigger. And if you're not mentally wanting to go through all of that, then the other option is we can get you, have some, my favorite thing was having some PMR consults to have them talk about what it's like to have that experience of an amputation, so that, again, patients have the opportunity to go through that emotional and physical kind of experience, that then they can make the decisions that they can. But oftentimes patients want options. And so to have the kind of expertise that you bring to the table of not just complex osseous reconstruction, but then the soft tissue coverage and stabilization through things like external fixation. And I know there's a lot more podiatric surgeons that are going into some of this world of orthoplastics. I think it's wonderful to just continue to find the options for patients. And when is this an option for patient with X, Y, and Z? And when is it, these are the things that put you at a different risk profile that I don't think this is a worthwhile risk. And having those discussions, those aren't easy things. But again, that's expertise. That's really being able to engage in that relationship with patients. And there's so much value in that. Even if it doesn't work out, patients appreciate that experience. So I really appreciated, we had some conversations earlier in the year at a different organizational event, but I appreciate that very much about you, this idea of maintaining not even collegial relationships, which obviously is important professionally, but those true interdependent patient and patient family member relationships. I'd love to shift into your experience with the Michigan Podiatric Medical Association. But first, we'll hear a quick word from the American Podiatric Medical Association, and we'll be right back.
Jeff, I'm really excited. We're taking Dean's Chat back on location, on the road, this time at the the APMA conference, this summer in Dallas, Texas.
That's right. We'll be in Dallas at the Gaylord Hotel between July 24th and 27th. And we'll actually be recording Dean's Chat episodes at the Pod Expo, which is in the exhibit hall.
Yeah, and I heard it's adjacent or right next to a pickleball court, which sounds like a lot of fun.
Yeah, they're going to play pickleball actually in the exhibit hall. And I think it's sponsored by Skechers. And rumor has it, Megan McClellan's been training for it.
Yeah, I'm going to need to do some training for it. I thought I might recruit your son to give me some tips.
I'm sure he'd be up for that. Well, I am really looking forward to catching up with all of our friends and colleagues in Dallas. And if you've not registered for the APMA National yet, go to apma.org/thenational and sign up today. Please do stop by the booth too when we're in Dallas. We'd love to interview you for a Dean's Chat episode.
Yeah, we love connecting with our audience and our past and future guests. So please come by and say hello. And now back to our incredible guest on the show.
All right, Andy. So you are currently the president of the Michigan Podiatric Medical Association. Prior to that, though, you have an incredible list of, and you're still a very young physician, so you have a remarkable list. I'm just going to read off a couple for the audience to have kind of a perspective. You were previous chairman of the Young Physicians Committee, part of the Licensing and Regulation Board, the House of Delegates Elections Committee, Insurance Committee, Strategic Planning Committee, Legislative Committee, and the Physician Parity Committee, or just a couple that I've pulled from your CV. I'd love to know what got you interested in being part of the Michigan Podiatric Medical Association.
Well, I think that goes back to, I think I mentioned his name before, but Kevin Kreitman. He was always involved, APMA, everything else. And when I came out, I knew that I didn't want to just, I can't just see patients. I got to do something else. Like I have to do, like my mind can't just work that way. And he was like, you're going to get involved. So I still remember we went to one meeting at a steakhouse here, and he always used to like to have me get there early, and we'd sit at the bar and hang out a little bit. And I still remember him talking to me. And the next time I looked up, I had like 4 people on the side of me. I had Scott Hughes, I had Randy Kaplan, I had Jody Sangstack, and Crystal Holmes, and I had all these people around me. And they looked at me and they said, "Okay, so what are we going to do to make you the next president in a few years?" And it was just like, I was like, "Okay, here we go." And so that's how it started. And you know, I was kind of looking for some sort of guidance with leadership. And now APMA has the YPLP, but before it was the Young Physicians Conference, the YPC, something like that. And they were doing it in Nashville, and I wanted to go, and the state was like, "Sure, go ahead." And when I went there, Stephen Schmidt, who trained at DMC and is now up in Minnesota, he was at that time the liaison to the board of trustees for APMA, and he was there. And I'd briefly known him when I was a student. He was a resident. And one thing that he said stuck with me was never say no. He was like, it doesn't necessarily have to be what you want to do or whatever, but when you're starting out, never say no. Say yes and figure out a way to make it work. You don't have to do it forever. And that's how I got into a lot of these committees and then started getting more and more involved. It just kind of, I still harken back to hearing him say that in my head. So that's where that came from.
Andy, with all of those committees, and you were also on a PAC committee, I believe. What's your favorite political arena within the profession of all the different types of committees you've been on?
You know, PAC is something I know is important. And for Dr. Kaplan, give to APMA PAC. I'll say it right now. PAC is interesting, but it's not my strong suit. I'm not a fundraising type of guy. I like more of the backroom stuff. I like more of the talking. I like meeting with the legislators and having that, those like the Hill days. And while I've done some stuff nationally, most of the stuff has been done at the state level. For instance, was it last year? We had randomly, they decided DPMs could no longer write home care orders under Medicaid rules in Michigan. And my PA, who I supervised, could write for the home care order, but I couldn't. And so started making some phone calls to our lobbyists. We met with a couple legislators, and without even legislation, we were able to have a rules change forced right through, and we were, brought back up. And to go into Lansing and be able to do those types of things, it's fun. We just recently had an educational license issue where there was some weird quirk with the way the new rules got written, where none of the new residents coming into Michigan were possibly going to be able to get their license. And with a couple phone calls, we were able to fix that all and have the entire thing streamlined so that they don't have any problems anymore, and they're all going to be processed. And those types of things where you can stop a problem before it becomes a problem, that's what I enjoy. I think it's fun. So,
Joe, what was Randy Kaplan saying? You're either at the table or you're what's for dinner or something like that?
You're either sitting at the table or you're on the table. That's always what it is. So,
oh my goodness.
And Andy, I think, again, this really reflects back to your idea of relationships. Sometimes little shifts start to happen, and then they kind of start to shift a little more. And if you can get ahead of that just a little bit before it falls off the table, like what an amazing skill that, again, serving your state for sure, but having that expertise to just make sure that the conversations that matter, the legislation that matters, that we continue to move things forward. I know there's been a lot of hullabaloo about all of this kind of reclassification with Optum. As you are in this presidential role, what do you think are the biggest challenges for future podiatric surgeons moving forward?
I guess number one is we have to maintain our, independence of who we are. Like I said, we're different, and it's okay to be different, and we have to be really good at being different. Yeah. But I think that we need to be able to maintain that while still working our way into being part of and seen as equal with other providers, if that makes sense. Like, it's kind of this weird tightrope walk we need to do. we're really, really good at what we do. And we need to make sure people know that. And we need to be the best at it. Like I think you mentioned what Dr. Yoho said. I remember him saying something very similar to me when I was at DMU. And I think it's, we have to maintain that excellence because unfortunately, whether it's fair or not, we're always, we can't put that 1 foot out of line. We don't get that leeway all the time. And like I said, I'm not saying it's fair, but it's also reality. But if we can maintain that, I think, while also, maintaining and being seen as equal with our MD and DO, I think that's really where we need to be. And I think that encompasses a whole lot of things. That's everything from the R1, R3 issue to call pay to everything. And I think those are, the issues, whether you're at the state or the national level. What's one thing that they try and do? Kick us out of Medicaid. That's happened in Iowa. I know that's happened in Michigan, and it doesn't take very long for us to get back in.
I say it happened here.
Yeah, yep. But I mean,
it failed miserably, and they were like, "Please come back."
and so I mean, we have our value, and so it's I think it's just being able to maintain that, and not. I think it's very easy to fall into a situation where it's like, well, we just need to get rid of the DPM and make us MDs or DOs and make us a subspecialty of medicine. And I don't think that's the right thing. We are different. We are biomechanical surgeons. We aren't just surgeons. We do so much, and we have the ability to do everything with regards to the foot and ankle, and other specialties don't. And it's something that sets us apart. And I think as long as we hold on to what makes us special and we become really good at what makes us special, we're going to be fine. But it's not easy.
Yeah. So, that's probably the best I've heard anyone explain that. And I think that's also what makes it so complicated, right? It's not as easy as just asking for parity, because we are uniquely different and we want to be uniquely different. So how do you fit into that space? That's brilliant. And I'm so glad you are in that position to carry us forward. Jeff, your thoughts?
Yeah, Andy, I was going to ask you, for other young practitioners out there that are seeing challenges that are legislative in nature, what is the path that you took? Who's your first call to? Is it your director, your executive director of Michigan, or do you literally have a Rolodex of the people that can make a difference for you? What advice would you give for young practitioners around the country in different states that see a problem and they want to make a difference in the form of change?
I think part of it depends on, number one, how involved you are from the get-go. I think when you're involved at different levels, you have different phone calls that are number one. I know that I have a lot of people in Michigan who will call me, or who call a couple other people in the state and they call me. And I think it's just, you need to have that mentor, that person that you go to, whether that's inside your practice, whether that's across the road, whether that's across the state. I think you need someone within your state who you're close with, who's been around at least for a little bit. And that can be someone who's 2 years older than you. That can be someone who's younger than you. I mean, I learn stuff from people that are younger than me all the time. That's one of the great parts about working with residents. And I have learned so much from everyone that's come before me, and I continue to learn. And I think you need to know who that person is for what issue. And if you don't know, you just send a message to your state organization, and then they call the right people. If someone calls me and I'm like, hey, and it's a billing issue, I have two people, one of them, Dr. Evans, you just had on. He's one of my first phone calls, and I start talking to him. If it's a legislative issue, it's to my executive director and my lobbyist. And it's like, hey, I need this and this. What do we know? If it's an education or residency issue, Dr. Zishan Hussein in our state does amazing things and is super connected across the state. So I'm calling him and talking to him. I think you just need to know who you need to go to for what it is. And that's one thing, especially, being president, I've learned is you can't know everything. You shouldn't know everything. And there's a lot of people that know a lot more about real specific things, and you need to utilize them every chance you get.
Yeah. Realizing that you can make a difference is maybe the first step, and then you can go about it. So congrats to you. That's fabulous. Joe, may I ask one more question? Andy, you said earlier that you never say no. And then weren't you at an ABFAS event recently, and you're so active in everything. You can't be everything to everybody forever. What's your favorite activity? And is it, you said politics is part of it, but you're a surgeon, you're double board certified. I mean, life is going to get super busy for you.
It has been. Yeah. I mean, now I've had to start saying, I've had to start saying no to certain things, I think that's the hardest thing, is figuring out when you get to that point where you can say no, because you almost you get to a point where you don't want to pigeonhole, but you need to kind of start pigeonhole a little bit. And I think that through a lot of this, I found that I enjoy working with residents. I enjoy working with them. I am not cut out to be a residency director. I don't have the patience. I don't have it in me. And you learn that as you go through. At one point I was like, oh, maybe I could do that. No, I can't. I don't. That's just not in my nature. At the same time, there's a lot of people who have no desire to get into some of the detailed legislative stuff, getting into the rules, into that. And I actually don't mind that. And I find that policy, the bills, and then to a certain extent, the billing and coding that kind of comes with it and extends from that policy. I think that's really where I have a lot of I like it. And so that's where I kind of see myself focusing. I do enjoy certain stuff with ABFAS. I don't plan on stopping that anytime soon. I like the relationships. I like the different dynamic. And I also think it's important that you have people who are involved in the different organizations that might be higher up in one, but still float and work in the others, because I think that it's good that people don't see this person is bad or these people have ill intent. They really don't. We all just want the same thing. It's just we may have a different way of going about it. And if we can understand why, we might come to find out that it's not the worst thing.
Yeah.
So,
and it really facilitates that team approach too, where you had mentioned in the very beginning, this idea that, it's okay to lean into the stuff that you find the most joy and satisfaction in your own practice. And maybe that for you, that wasn't the elective reconstructive sports medicine, but for somebody, maybe it is. And Javon Bass had talked about this too, this idea we kind of get stuck in these silos where we are all on the same team. We're all working toward the same goals. And so I agree with you. It's really important. And Andy Meyer has done some work here too, looking at this idea of how many people are in committees across different organizations, because that's also how we start to hear each other's perspective, and we start to work, or continue to work, I should say, together to improve the profession as a whole, rather than just this one little niche that I live in, right? So I very much can appreciate that. And even if you don't think that you're in the wanting to be a residency director, you did win the Faculty of the Year award for your residency program. So your residents love working with you. And I would love to get your take on what are your favorite parts of education? Because you've certainly also lectured, you have a long list of lectures that you've given at different conferences. What is it that you enjoy about the educational experience with surgical training?
I think it's when you finally see it click. I think that there's something to it when you see someone and something you say or something you do, you explain it 6 different ways, and somehow the 7th time they get it. And you see them go from, I'm thinking of one resident in particular right now who's graduating, that when I first met them, they were hands like this trying to suture. Couldn't even throw a simple without and I remember the first TMA I had them suture up, it was longer than it took us to do the TMA. And now I walked in, I walked in to do an MIS bunion, and they threw the wires faster than I could. And it was done, and it was perfect, and it was right there. And it's just looking at them, and then them purchasing a practice and being excited about moving out and asking these questions and being able to go to that 3rd and 4th level that they never would have been at. That growth is what I find. And, I've said it to them, and I'll say it again. They should be better than me. If they aren't better than me, I haven't done my job. I should be the basement. They should be way above where I am. My mistakes, they shouldn't make. They should, I should be the one that made the mistakes so they don't have to. And I think that's, just watching them grow and watching them get better. That's what we need. And that's what I enjoy.
Love that.
Fantastic. Andy, if you don't mind, do you mind commenting on mentorship? I know you mentioned Dr. Kreitman.
Yeah.
As a mentor of yours, but we all have many mentors in different times of our lives, and people that were important to you so far in your career in influencing you.
Yeah. I think, number one, I have to look at Dr. Loader and what he did in my residency. He, at the time, man, some days it was, but that's what was needed. And I look back, at it now, and it's like, no, that was, he really helped me with efficiency. He helped me with understanding and kind of making sure that your head's in the right place and being able to assess pathology in the right way. And sorry if you guys can hear the dogs, they're going nuts. And then, following that, I think Dr. Kreitman is still probably the most instrumental overall. He really kind of guided me. I came into his practice, taught me basically everything. And he was that person who would just lay it all on the line and be there for you no matter what. And then, as I moved on, I found different mentors in different areas that do different things. I look at, I have Dr. Hughes and with the stuff at APMA now, and some of the people through there, whether it's Dr. Helper, and then even people such as Dr. Albright, who you had on. I mean, she's absolutely amazing, and I have no idea how she has time for anything that she does. And then you just learn to see what they do and how they function, and you learn different ways. And they all approach problems differently. And seeing the way they approach problems and work to remedy problems, or maybe look at something and approach it is beneficial. And I like taking those types of things away from them. So.
Well, when you said that you wanted your residents to be better than you, that's a classic mentor line. I'm sure they are looking up to you as a mentor.
Yeah, I mean, you like to think so. I find it difficult, though. I mean, nowadays, I know we all talk about it, but there is how do you motivate people? How I was motivated nowadays is a little different. I mean, I found myself reading books on how to do it. And so it's just, you want them to be better, and it's just how do you get it to click? And I think the one thing that I found is that everyone is different. And you need to just find what works for that person in that way, and then try and build on that as much as you can.
It's fair.
So.
Yeah, that meet them where they are and help them craft the keys of what's important and how they can bridge those gaps. And that is not an easy feat.
No.
That's like I'd love to bring you back to a whole other podcast talking about like tough love and the difficulties in, are you a parent, Andy? Because this also, my mentality is very different now being a parent and interacting with residents. It's very funny to see the shift in how you perceive things. So some fun things we'll have to bring you back for a second discussion. Do you want to rapid fire, Jeff, or do you have any other questions?
Yeah, let's go for it. Rapid fire is my favorite. Right. By the way, Dr. Loader, we had him on the podcast. We really enjoyed it.
Yeah, we'll have to put a link at the bottom, because you have had we've had a lot of previous guests that were important in your past. So that might be a fun reflection episode. So, all right, Andy, what kind of music do you listen to in the OR?
Country or EDM?
Oh, you're an EDM guy. Oh, I love it. Okay. Or country, but I have some funny stories about people that they either love EDM or they do not want it on in the opera.
I know.
All right, Andy, big occasion. You're going out for dinner in Detroit. Where are you going?
God, I think probably one of my go-tos is always Lumen. It's a restaurant with a nice rooftop, and it's over in just kind of out of the way a little bit. Always consistent food. Love it.
What kind of food?
Steakhouse kind of, but like modern steakhouse. So they still have you have seafood, they have steak, and the cocktails are good. So I enjoy it.
Okay, I'm going to piggyback then. Are you a cocktails or a wine guy?
Yeah, primarily cocktail.
Okay.
Primarily cocktail, usually whiskey.
So what do you do to relax when you're not involved in podiatric medicine in one way or another?
I found that I have to occupy my mind. So it's either cooking, it's reading, or I have this whole thing where I think in my second life, I'm going to be a soccer player. So I play some beer league pickup soccer and try not to hurt myself. So, something like that.
We'll have you meet Jeff Baker. He's a big soccer guy, and he's not necessarily close to you, but somewhat regionally close to you. So on the books thing then, what's one or two most influential books for you?
Books that I've really loved. I like Outlive, that came out. I really, really like that. And then actually still one of my favorite books is Ghost Wars, about the CIA involvement in Afghanistan in the Soviet era. I absolutely love that, so.
I don't know that one. Yeah.
So.
It's always interesting to ask about specific books, because when I think about that, I think of authors, different authors, because once you jump on an author and you start reading their books, it's the ticket.
Yeah.
I just think that's great. Okay, next one. Let's talk. Are you into sports like football?
Yep.
So what do you think about the Lions this year?
Well, this is going to be a make or break it. I think this is a real kind of like see what they're made of type of year. I mean, you had Ragnow retire. You had both your coordinators go. You didn't make any major changes. So let's see what you're made of. The one thing I will say is, until he proves me wrong, I'm going to trust Brad Holmes. The guy has not failed me yet. So, I think their chances are good. I don't think they're going to have a year like last year. I do think that they'll make the playoffs, but the NFC North is tight. It's really tight. And having Ben Johnson over in Chicago is going to make those games real fun now. So.
I think I'm a Packer fan. I grew up in Wisconsin.
Okay.
And I think the Lions are at Lambeau Field September 7th. So if you get a crazy idea to go to the game, let me know.
All right.
So I'm going to go deep for a minute.
Okay.
Is there something that you did as a kid that you really loved doing that you don't do anymore? Hobby?
Yeah. And it's probably, so what I used to do a lot of, I was in Scouts and I used to do a ton of camping and backpacking. And I just don't have the time right now. And it's just finding that time to go back would be wonderful. I've always wanted to hike parts of the Appalachian Trail, and go out that way. And at some point, it's just going to be later in life. But yeah, that's the one thing that I used to do. And I miss the nature aspect. I miss just being quiet and having a fire and that cup of coffee. But someday it'll come back around.
Yeah.
I'll go for one of those deep ones too. Andy, what were one of life's aha moments for you?
I think it's actually when, what I talked about earlier, when, I got left, the PhD program said no, and you're just kind of left with, you're finally faced with failure at some point. And I think it's important. I was lucky enough, I didn't have a ton of it. School was pretty easy for me. I got through a lot. But I think that it's really important to fail. And it's important to realize that it's not the end and that you need to just change, and that it's just a change of course. It's not a failure. And it was, that was a tough couple months trying to figure out what to do with my life. And looking back, it was probably one of the best things that happened to me. But it's just like, you need to be able to start seeing things that way. So when they happen, it's what happens.
Hey, our profession's glad you went that direction. I can tell you that.
Most definitely. Yeah.
Any more, Joe? Any more?
No, I think in the interest of time, we will save further rapid fires for part 2 when we start talking about feedback and coaching and Get Andy on for some of those. I've had a couple of residency faculty or directors with some common themes, and I think this would be really fun to explore. Because I don't think any of us have the answers on how to bridge these gaps.
The best, there's one book out there, 10 to 25. It's the best one I found. So
fantastic.
We're going to dive into that on the next episode, Joe.
Sounds wonderful.
I guess maybe this would be on that theme. What would be one piece of advice that you would give a student getting ready to go on their externships, going into this world of residency training? What's one piece of advice that you would give them?
I guess it'd be kind of twofold. One, be yourself. Don't be someone who you think the residency program wants you to be. Be who you are, because you can't fake it for 3 years. You can fake it for a month. And number two, start to get an idea of what kind of practice you want, and realize that you can get wonderful training anywhere. And that whatever type of practice you want, that's the type of residency program you should look for. If you don't want to really do trauma, don't go to trauma heavy programs, and there's absolutely nothing wrong with it, and don't feel bad. Vice versa, if that's what you want, focus on those programs.
Oh, I love that.
Yeah, super well said. Well, Andy, we thank you for making time to join us on Dean's Chat. Appreciate it.
Thanks for having me. I appreciate it. It's wonderful.
You're welcome. And to all of our listeners out there, if you're listening on Apple or Spotify, please give us a 5-star rating, or better yet, leave a comment. And if you're watching on YouTube, by all means, become a subscriber. Joe and I will continue to bring you leaders in the profession. And I don't have my Dean's Chat cup on me today. Joe, do you? Oh, there it is. We're going to send you a Dean's Chat cup, Andy.
Wonderful. That's awesome.
There we go.
Thank you.
Yeah, we have a new slogan. Start your day the Dean's Chat way.
Yeah, Dr. Eric coined that, and now we're going to totally steal it.
Yeah, we got permission though, so it's all
we
good.
did. Yeah, we did.
All right. Well, cheers, everybody. See you next week. Bye-bye.